This slide just shows that HMU doesn't work in isolation. We collaborate with different institutions of the government, but monitoring different thematic areas: financial audit, service delivery, essential medicines, and health supplies. And so the success of our work depends on the collaboration with these people. Now, in the region in question, we've monitored 3 districts. Tororo was done earlier, outside the financial year, but the findings are pretty much the same, and I'm going to focus on Sironko and Manafa. Mbale Regional Referral, we are still doing the monitoring. This map has been referenced a lot, but I want to mention that one of the biggest problems in the region is we are treating beyond the catchment area. People who are living in Kumi, Bukedea, Ngora, they come to Mbale Regional Hospital. The health workers, when you have this small salary, but you have to feed the whole clan. Now, our approach, I'm mentioning this because we have the presidency in the district, the RDCs. You're supposed to do this same work we are doing within the district. We have entry meetings with the leadership, we monitor service delivery, and we also do on-job training and mentorship. We develop aid memoir. This is a tool to aid the memory and have action points which will be followed later. We do stakeholders dissemination meetings. We do community dialogues and radio talk shows so that the community can own. This is an approach that the president recommends. Financial audits, and then we go into criminal investigations for negligence, theft, and any kind of impersonation. And we do follow-up visits, including forensics verifications. With cases where forgery, signature of the accounting officer is forged, we take this for forensics, and we've actually found the culprits. In our work, we also document best practices. I want to disclaim, HMU is not witch hunting. We don't look for problems. Where we find good practices, we document. However, Genesis chapter 4 and verse 7, God asked Cain, if you do good, will you not be appreciated? So definitely, if you do bad, there's a problem. Now, we have facilities there in Sironko district and in Manafa, very well maintained. Those who come from there, isn't this true? So we report the positive findings as well as the negative. However, because we are looking for areas of improvement, let me dive into the key challenges. Leadership. The DHOs, at the time of visit, the 2 districts both had acting DHOs and a number of people in the DHT who are in acting position. Now, when you're not substantive, you know you're squatting. Tomorrow you'll be taken away. So you dance to the tune of whoever puts you there so that you stay longer. Governance. Support supervision is done, but they are not action-oriented. You find that most of them is signing the book, ticking the box, but then you visit the facility, and the facility which is given a good rating, still there are problems. No CPDs on client charters and ethics given to the health workers. Supervision. Some of the officers did not visit the facilities in a whole, all the facilities. However, some of them visited, notably in Sironko. I don't know if the cow is Sironko is here. Yes, cow, stand up. So at the period we visited, the cow and the acting DHO had visited all the 12 facilities in the catchment area. Now, if the cow can visit, who be you an assistant DHO not to visit? Who be you a sub-county chief not to visit? So that is leading by example. We have staffing norm. Whereas there are gaps in Sironko, Manafa had actually an excess of staff. And you know that affects the budget. It brings issues and complications. Duty attendance, organized absenteeism was well described by Professor Driwale. I don't think I can say it better, but this is quite rampant. We have facilities where in-charges are absent. They attend very little, and you know, fish starts rotting from the head. When the head of the home is away, the children can play. They can be away as well. Then there are unsanctioned study leaves. There are dual employment system. In one district, we found that one officer was employed by 2 districts, in Lira district and in Apache. How did it happen? One district was still in IPPS, this one is in ICMIS. So he beat the system, dual employment. Here we have NGO. So NGO partners, you need to validate this before you pick up the district staff. Wearing uniforms, only the medical officers were found in full uniform. The rest of the staff, nurses come with the open shoes, which are not within the ethics. Some of them don't have name tags because of an extortion. Then there's an issue of overstay in a facility. If you've stayed for long, you then become complacent. And then the errand staffs were 18 in Sironko. There were already disciplinary measures, while in Manafa 3. Now, if you look at in-charge's attendance to duty, in 3 months, the in-charge of Bukinamai has attended only 7 times. Yet we expect about 23 working days in a month. But when you're in charge, you should come every day. So these are issues. You can see in-charge's attendance to duty, OPD service delivery. The numbers are very few. Now, look at the same facility, 133 patients seen in OPD in 1 month. Meaning, they are seeing less than 5 per day. A health center 3? These are the kind of actions that you should enforce. Antenatal care and delivery. We see that the 4th antenatal care is slightly less, the deliveries are more because a number of mothers don't attend antenatal, but also referral. You could attend ANC in Health Center 2 and go and deliver in a Health Center 4. But let's applaud the Health Center 4, which has a very big delivery. You can see at the bottom. Okay? The rest, now these lower numbers attribute to the overload in the regional referral, because they are sending everybody to the regional hospital. We compared SVD, normal delivery versus cesarean section. And you see that cesarean section rates about 25.6% in Budadiri. Buasa is 15%. This is slightly low, especially given that there is no district hospital. So, when you analyze like this, you put them down. We even go ahead to do a cesarean section log per doctor to know how many. In one district, not in this region, a senior doctor, a gynecologist, did 20 cesarean sections in a whole year. And that was it. No total abdominal hysterectomy, no laparotomy, no nothing. Yet the junior staff supervised by the doctor would do like 20 cesarean sections in a month. So you should question, what are you doing with your time? A gynecologist, no TAH, no laparotomy, what are you doing? There are key maternity issues. They have already been alluded to. Maternal death, fresh stillbirth, neonatal unit being congested, extortion, medical negligence. And then the bigger issue is referrals. Dr. Mugai, I think we need to do a detailed study on referral patterns to look at referral in and referral out. You'll find that in Kamuli, for example, many of the referrals are coming from outside the district. And then they overload the facility because supplies are given based on the catchment. So referral patterns, and then the other one is for Dr. Driwale, monitoring productivity of health workers. We can choose the specialists, especially the surgical, and we see how many surgeries they've done per given time. It is beyond just signing the biometric and attend and being there. I brought this analogy. In Acholi culture, we say a woman delivers with the help of a co-wife. This is Kamuli General Hospital. On this day, 20th of May, this mother, poor mother of 45 years, gravida 7, para 6, with one previous car, had labored for 2 days, 50 hours in a health center 3, then was referred and brought. Even when she came to that hospital, still 2 hours. I saw her lying in theater. The doctor was absent. Then I called the medical super. I said, let's go and operate. Fortunately, I still do surgeries, and that's me doing the cesarean. In Lira, there was Ugur Health Center 4. Very nice theater. It was never opened. The first surgery, I did it. So we keep doing. We encourage. Now, the MS told me, after you doing this, I'll never say there's absent doctor. I must go and do the surgery. But this was a risky mother. Essential medicines and health supplies, you can see a very nice, well-organized store. Who is from Bubulo Health Center 4? Do we have somebody from there? Stand up. Yeah, this is your first store, well-organized. But now, look down. The facility where the in-charge attends only 7 days in what? 3 months. You see? Empty shelves. So we can connect these dots and really know. Please take note, NMS delivery is also a problem. Dr. Siraj talked about it. I have also a mention about general stockout is common, theft of medicine. Please, whoever is responsible for medicines, there is a very organized system of stealing medicine. They fill all the documents together, they take the medicine, but it's not dispensed. We found in a facility where 200 doses of artesunate was requested in 2 days. But the whole 3 months, there are 60 patients. So where did the medicines go? So we need to dig deep and find out this. It's like if your daughter comes with an iPhone, yet you can afford Kabiriti. You have to ask her, who bought for you this? Now, look at NMS performance. The summary of this is that these facilities spent, the supplies meant were delayed by 54 days from the scheduled date of delivery. And then for Bubulo, 56 days. So what do you expect the poor doctor to do? Now, we did analysis in the medicine store. I don't know if it's Bugobero or Bugobelo. We have issue with L and R, no problem. But just a spot-on-spot audit, 10.5 million worth of medicines for the selected tracer items could not be accounted for. Because you don't supervise the in charge of the store, so he has made the medicines growing. He was arrested and investigations are ongoing. Now, look, Sironko Health Center for staff houses. There's maize, we want side income. But next to it is a brand new autoclave, sucking all the dust and aflatoxins and pests from the maize. This one can grow wings, and what do you do? So there's need to check everywhere as you go and monitor. Now, I mentioned that we do community dialogues. This is my second last slide. Communities raise issues and identified health workers. You don't know whether it's a nurse or whether it's a doctor, whether what. They are not identifiable. So when they extort you, you cannot report. Rude and unhelpful, extortion I mentioned. Shortage of stocks and supplies, we've already mentioned that. It's notable that blood consumption is the highest in Uganda in this region. I'm in touch with Dr. Bumba, who happens to be my able student, together with Dr. Siraj. They are doing very well, and I'm happy. I taught them in medical school first year. They are doing good job. I'm a sportsman, so I play soccer, striker, center forward. Yeah, so poor infrastructure. In order for us, and this is especially for the political leaders, in order for all these things to work, we don't need to prioritize one and leave the rest. The building blocks need to stand together. So you have a doctor who wants to operate, who has the skills, but the theater is not working. No anesthetist. You have anesthetist, no anesthetic machine. So this kind of thing needs to be looked at in context. Poor unethical conduct, we've talked about that. Lack of accountability. There's a facility I went, if the in-charge is away, everything is locked, you can't access the office, you can't do what? Ambulances. Some communities have challenges, there's no ambulance, but also, Dr. JB is not here. I think further to the discussion, the minister identifiable badges so that health workers can be known. We are investigating all the unethical conducts to improve drug availability, dialogue with NMS. Last week, we had a meeting in Mbale Regional Referral Hospital, and there was NMS representative called by the director. Then improving infrastructure. Yes, look at the Regional Referral Hospital here. Maternity, one operating bed for the cesarean. There's the other theater as well, but still, the numbers is big. So the more practical solution is the health center falls within vicinity, should be equipped, and mothers are operated there. I think one of my colleagues is here, Dr. Mulwani. He was in Anaka Hospital. They didn't have anesthetic officers. So they would bring us referrals. But our director said, now, you're the doctor, but you lack anesthetist. Here we have anesthetist, so you enter to theater with your patient. So 2-3 times you bring, you go to theater and you operate. Because the problem there is anesthetist. So let's enforce that. In the regional referral hospital, When the numbers are big, you equip these facilities, especially the ones closest to the city. Make them a high-volume health center so that they can decongest the ward. I think, Dr. Jude, you agree with me. So, finally, we have a toll-free number to report any concerns. In February, I was in Mbale District monitoring. When I presented, the RDC said he feels that we should teach the RDCs and the local council leaders on the framework of monitoring, because HMAU cannot be everywhere, every time. So probably it's our collective responsibility to see that health services are delivered for God and my country.
Chairman, you see? Let's give another round of applause to Dr. Ataro Ayela. Thank you very much. And I think that is going to ground our discussions deeply in the breakaway session. I would now want to invite the RDCs, the DHOs, the COWs, officials from the Ministry of Health, OPM, Health Monitoring Unit, the Chief of Parties, LC5, and Dr. Dwale to stay here in this room, and then the rest of the team will go in the lower section. Enoch, where are you, or Moses? Time. We're really behind schedule. Maybe we'll have them in the... Yeah, I'm just constrained by time because we have this breakaway session and then we are going to come back. So we're a bit behind schedule and it's 4:30. Yeah. So the team going to the lower section, please, you'll follow my dear brother Enoch as well as Moses. Okay, Moses is there and Enoch, the team going to the lower section. Then the team that is remaining here, all RDCs, DHOs, COWs, MOH, OPM, HMU, Chief of Parties, LC5, and Dr. Drery can stay here for a breakaway session. After that, we will reconvene and we'll come up with a position of the assembly on a number of things. All right, let's do this. Great. Back-end team, give me some little music as people get out and we reorganize the technical